This is the Dr. Joaquin Rosales, the chief of hematologist group.
Fine.
Dr. Nicolaus.
Shall I start with my presentation? Hi. Hello. Hi. Yeah, can you share so that I can share my screen? Yeah, is possible? Let me see.
Alguien si quiere se puede unir y grabarla por si de pronto no queda grabada. Calma.
Can you see my slides?
No. No, doctor.
No? Wow.
No, señor. No, sir.
You cannot see it. Okay. Let me see what's wrong.
We are already seeing the screen.
Right, okay.
Yes.
Also the presentation? Yeah?
Yes.
Okay. And you can hear me as well?
Yes.
Okay. You should let me know when I should start.
You can start right now.
Yes.
Okay. So thanks very much for the invitation to this virtual presentation in Cali, Colombia. Never been in Colombia, but this sounds very nice. And you asked me to give a presentation about the current role and advances in allogeneic stem cell transplantation for patients with myelofibrosis. And so my lecture will be, as you proposed, about 35 minutes roundabout, and then we can have your cases and we can discuss some issues. So these are my conflict of interest for this presentation. And just briefly, if we discuss about myeloproliferative neoplasia, so the usual, not the rare MPNs, but the classical MPNs is actually the essential thrombocythemia or polycythemia vera. And to be honest, there's actually no clear indication for this kind of diseases, unless they become blastic phase or secondary leukemia, which happens more in PV than in ET, in about up to 10% of the patients, or about 10% or 15% of patients with PV or AT, they can transform to what we call post-ET, post-PV myelofibrosis. The majority we're talking today will be a primary myelofibrosis, and this patient can also transform into blastic crisis. Not all, about 20-25% of the patients, they will transform into secondary leukemia. So I will talk mainly briefly about blastic phase and then mainly about myelofibrosis and stem cell transplantation. So the disease itself was just described about 150 years ago, and it was described as 2 cases of leukemia with peculiar blood and marrow findings. And the hallmark of the disease is this huge spleen, and the other is the fibrous material in the bone marrow, as you can see on this slide. And those patients usually have also constitutional symptoms. And these were the classical symptoms which were described 150 years ago by this, at this time, very young German physician. So because you can imagine, if you are involved in stem cell transplantation, having such a huge spleen or having such an unpleasant environment in the bone marrow, most of the transplanters are very reluctant to transplant this patient because you can imagine it will be very difficult for stem cells to find their niche in this unpleasant environment. So the first reports, even if in MDS and acute myeloid leukemia, transplant was also done in the late 70s, 80s in the last century. The first report about stem cell transplantation in myelofibrosis came in 1999, and this was a combined work between the EBMT, the French and Italian Society in collaboration with Fred Hutchinson Cancer Center, and they collect only about 55 patients who received an allogeneic stem cell transplant, and you can see the median age was pretty young, 42, though this does not reflect the common age at diagnosis, which is about 65 up to 70 years of age. But nevertheless, in this report, they could see about 50% of the patient could be cured by allogeneic stem cell transplantation. The outcome was better if there was a completely matched donor. But you can see here in the beginning in this Kaplan-Meier curve that the non-relapse mortality was pretty high, about 30%, even if the patient were quite young. So you can imagine that then when we look to our European data registry, you can see up to the age of 2000, 2003, there were only very few patients who received stem cell transplantation in the European Registry for Stem Cell Transplantation, the EBMT. So you can see less than 50 per year are transplanted or were transplanted for stem cell for myelofibrosis in Europe. And you can see below the median age, these were pretty young patients, so in the 50s or early 50s, which, as mentioned before, this does not reflect the current median age at diagnosis for this disease. So what we did in the early 2000s, we started a process when the reduced intensity conditioning was introduced. We started within the EBMT a prospective studies, multi-center, multinational studies, where we investigated busulfan fludarabine-based regimen and using also patients now at the age of 55. So the median age was higher than I've reported for this previous study. And we could include more than 100 patients. And the results were quite promising. So about 60 to 70 patients could be cured, especially if they have a completely matched donor. And there was a difference regarding the disease risk. At this time point, it's pretty old. There was only the so-called Dupré score or Lille score. So this was quite encouraging for the field in myelofibrosis. But even more interestingly, what we could find and what we could show then in the subsequent research is that especially the fibrosis could be rapidly resolved after stem cell transplantation. So this is just one case. So you can see usually this patient have MF3. That means they have a severe fibrosis, they have osteosclerosis, and already by day 30, you can see a nearly complete resolution of the fibrosis. You can see some residual osteosclerosis, and usually by day 100, the majority of the patient have a complete fibrosis-free bone marrow with good hematopoiesis and some residual osteosclerosis. And more interestingly, when we came up to look for so-called driver mutations to molecular remission, so the common driver mutation in this disease is JAK, CAL, and MIBL, we could also show that quite early by day 100, the majority of this patient already have a complete molecular remission if they underwent allogeneic stem cell transplantation. I will come to this a bit later again. We also checked because this is a highly inflammatory disease. So we did some PET-CT in some of the patients in collaboration with our colleagues from nuclear medicine. And you can see in the beginning, usually this patient have a very high inflammation in the bones. As you can see here on the left-hand side, this huge spleen. But interestingly, by day 100, you can see even the spleen is still very, very large, but you can see there is a complete or nearly complete resolution of all this inflammation in the bone marrow. And even more recent research is also investigating the osteosclerosis, which is probably a bit different from osteofibrosis. You can see that the spinal, the increase of the bone mineral density rapidly declined post-transplant. You can see the thickness of the trabecular numbers declined, and also this elevated parat hormone you can see here becomes quite normal after allogeneic stem cell transplantation. So taking all this positive development and this curative potential into account, you can see that in the next 15 to 20 years, the numbers of allogeneic stem cell transplantation, here data from the EBMT, but CRBMTR is similar, is rapidly increasing. You can see nowadays about 500 patients are receiving stem cell transplantation for myelofibrosis in Europe. And you can also see below that the median age of numbers is now increasing, and we are now in a median age of 60 and even going higher to 65 years of age. So this means that allogeneic stem cell transplantation is now a well-established treatment in myelofibrosis, especially in those patients where you can approach cure. So therefore, in my second part of the presentation, I will address some issues which are problematic. So when we talk about allogeneic stem cell transplantation, this is not just the conditioning on the stem cell infusion. So usually this is like a living drug. So and you have to select proper patient. You have to think about pre-treatment, as we do in AML and ALL, where we try to focus on MAD negativity or at least complete remission. Then we have conditioning, we have reduced intensity, myeloablative conditioning. We have different stem cell infusion, different donors. Then we have GVHD prophylaxis. And more recently, we should focus also about relapse prevention. And all this is really crucial during the course of the disease in the patient. And this is lasting, I would say, at least 1 year, because you can intervene at every step of this stem cell procedure in order to get the higher cure rate, which is for all patients about 60 to 70%. But we still have a risk of relapse, which is about 20% to 25%. And we have the risk of treatment failure by therapy-related or non-relapse mortality, which also is depending on patients' factors, but also on donor factors, is about 15% nowadays. So in order to reduce relapse and non-relapse mortality and increase the cure rate, we should really look at each time point how we can improve and how we can do better in these patients. So I will start with blast crisis. So blast crisis usually is not good. So you should avoid to wait too long if patient got into blast crisis, even if you can achieve about 30%. So 1/3 of the patient still can be cured, even in blast phases. These are data from the EBMT. You can see those patients who achieved a CR by induction therapy or do better than those who did not achieve CR. These are our own institution results. Here are the data below from the CIBMTR. They look more for cytogenetics or for unfavorable molecular genetics like p53. So you can see also here, around about 1/3 of the patient can be cured. But the main clinical message is you should not wait until patient got into blast crisis. So the other is the so-called accelerate phase, which is defined with blast 10 to 19%, either peripheral blood or bone marrow. And interestingly, there are very few data. So we did a publication a couple of years ago. And interestingly, so outcome in accelerate phase is not as bad as blast phases. You can see outcome is similar like the chronic phase, even if there is a slightly higher risk of relapse in this patient who still have blast between 10 and 19%. So also here, it's possible to transplant this patient, but it should be avoided, and it's better to transplant patient in chronic phase. So I will focus now more on chronic phase because this is still the majority of patients. And before we select patient, probably we should look about the regular outcome in myelofibrosis. It's my data from the Spanish, so still more than 10 years old. But you can see in the last years, you can see the median survival of all patients with primary myelofibrosis is about 6.5 years. And this has improved in the more recent years. Maybe it's improving now still because we have JAK inhibitors. But in the end, you can see with this survival curve, the disease is very heterogeneous. So we have patients, about 20% of the patients who still die within the first 2 years of diagnosis. On the other hand, we have also 10-20% of patients who are still alive at 15 or even 20 years. So we have to select patients probably, and therefore we come to the so-called disease-specific scoring risk for myelofibrosis. And this is just an example. We have even more. We have DIPS, which is focusing only on clinical factors, leukocyte, hemoglobin, constitution, symptom, age, and blast count. And we have DIP blast, which is then in addition cytogenetic. And then since the molecular marker become more and more important, the Italian develops its MIP70 score. We have also MIP70 plus score, which include beside the common factors also high molecular markers, which are defined maybe by ESH2, but also by A6L1 and others. And the MySEC is developed for the post-ET, post-PV myelofibrosis. They have also other risk factors. But with this scoring system, you can nicely predict the outcome for patients which do not undergo allogeneic stem cell transplantation. So this is the normal course of the disease. So since there was no randomization or no prospective study, when should patient be transplanted? So the community thought maybe only advanced patient would be good. And there are several models or comparison between transplant registries, non-transplant registries. There are sophisticated statistical models like left truncation, for instance. This was such a model where we compare transplant results to non-transplant results, and it becomes clear that patients according DIPS, intermediate 2 or high risk, benefit from an early transplant, while low risk patients do not benefit from early transplant. They benefit for conventional therapy, while for the intermediate 1 group, you can see early on there was a higher mortality in transplant, but then the curve crossed at 10 years around, so there was no significant benefit for transplant or non-transplant. CIBMTR did a similar study using other different statistical models. Also, they found benefit for early transplant for intermediate 2 and high-risk patient, no benefit for early and intermediate 1 patients. You can see here the curves cross already by 5 years. So it becomes a crucial point, should intermediate 1 patient transplant early or later. So what we thought then, because this was really only disease-specific risk factors, and it does not mean that those patients benefit from transplantation. So what we developed then in a large cohort of patients, we developed a score, a so-called transplant risk score, which allows us to predict the outcome after allogeneic stem cell transplantation. This is very important if you have patients and you counsel patients, and patients have a high risk, for instance, and then they would like, okay, what is my outcome after transplantation? And you can see, beside disease-specific and patient-specific factors, also transplant-specific factors are included. And you can see, for instance, here that, for instance, an unrelated mismatched donor has a twofold higher risk. This is the hazard ratio was 2, has a twofold higher risk of dying than a completely matched donor. And with this score, you can have then different risk score for transplantation. Between low, they have a 90% survival, or very high, they have only a 34% survival because of a high non-relapse mortality. So these were the corresponding figures. You can see nicely this separation between the different risk groups. And this holds true in the validation cohort. It holds true for overall survival and non-relapse mortality. So you might ask, how important is this for daily clinical practice? And I will give you an example, because what we did then together with our French colleagues, we looked in patients who have the MIPS intermediate risk according MIPS. And you can see this where the blue curve is the non-transplant outcome for patients with MIPS intermediate. This is just what we know. So the median survival is about 7 years. So this fits very well. However, if these patients received allogeneic stem cell transplantation, if they have a transplant risk score, which was low or intermediate, then you can see here the outcome was significantly better than the conventional therapy. But in contrast, if these patients have a transplant score which was high or very high, this is here in the red curve, you can see outcome is worse than the non-transplant approach. And this highlights how important it is not to look only, if you go for transplant, not to look only in disease-specific factors, but also include in your decision finding the so-called transplant-specific risk score. And this has then translated into a recommendation. This is a recommendation from EBMT and European Leukemia Net, clearly showing for DIPS intermediate or high risk, there is a clear indication for transplantation, and for especially if they have a low or intermediate risk according MTSS. And for DIPS intermediate or MIPS 70 intermediate risk, they should receive transplant only if they have a very low or a low MTSS low risk score. But also other things should be balanced, especially patient preferences, and other options, non-transplant options. So this was actually in 2023, but meanwhile, many things happened. So for instance, now we know that the P53, which is currently in discussion with AML and MDS, has also some impact in myelofibrosis. So in this study, we could find that about nearly 10% of the patients are harboring also P53 mutations. But those who have a single hit mutation, the outcome is not as worse. It's quite similar like the P53 wild type. But if you have a complex karyotype and P53 or B allelic P53, then the outcome becomes worse because there's a higher risk of relapse, even if you still can salvage about 30% of the patients. So all this new development, we will currently update this risk score, the MTS 2.5, and you can see other risk factors will come into the focus, like portal vein thrombosis. And this we can discuss later because one of your case report is included, this portal vein thrombosis, or other molecular markers will come into, like P53, and also quite important, the RAS pathway mutations have also impact, and this will be a new score or development of our transplant score according to the most recent development. So it's not so easy then to decide the proper definition. So you have to look on not only for age, you have to look for comorbidities, you have to look to the spleen, the other disease factors, portal vein thrombosis or portal hypertension. Molecular genetics becomes more important. And there's also some current developed risk score about the response to ruxolitinib. And then it's very important to develop disease-specific scores, transplant-specific score, and then to make at the end then the decision to go for stem cell transplantation. So this is very important. So for the patient selection, you should really select patient according MIPS and transplant-specific risk score. I will come now to the pretreatment, and unfortunately, we don't have any chemo which is useful in reducing the tumor load like we have in AML, where we try to get complete remission or we try to get molecular remission. So all the drugs we have is more symptomatic. So the major issue we want to resolve is to reduce the spleen size before we go for transplantation, because the spleen size has major impact on engraftment, has impact on so-called poor graft function. And currently we have several options. So we have the option to use JAK inhibitors prior transplant, use splenectomy, or more recently spleen irradiation. So several studies. So this is a larger study which we did in EBMT. We looked in outcome after allogeneic stem cell transplant in patients who received either ruxolitinib prior transplantation. These were 277 patients, and compared it with 274 patients who did not receive ruxo prior transplantation. And you can see here the results were quite nice for those who received ruxo and did not underwent allogeneic stem cell transplantation while they responded to ruxo. This is the green line here. This was regarding relapse incidence significantly better than those who did not respond to ruxo or did never receive ruxo or even failed to ruxo after they have started with ruxo. And this resulted in a better event-free survival and also a trend for an overall survival. The other option is splenectomy, which is currently not so frequently used because the procedure is not so easy. It's usually associated with complications, with thrombosis, bleeding. And this is a large EBMT study who looked retrospective on the impact of splenectomy. And indeed, so the engraftment was faster, and there was also a lower non-relapse mortality for those who received splenectomy. However, they showed a higher risk of relapse, and this was a bit of concern. So overall survival was not better for those who received splenectomy than those who did not splenectomy. The other option, which is coming more and more into focus, is spleen irradiation, because spleen irradiation is causing severe cytopenia, and usually the response to spleen irradiation is only very short, is a couple of weeks. And we and others decided to do the spleen irradiation just immediately before you go to conditioning, because then you don't care about the cytopenia and the remission is short. But you can see in this retrospective studies where we included about 60 patients from all centers in the world, you can see the spleen size reduction is about 5 centimeters in the median. You can see a drop in the platelet counts and also leukocytes, but there was not a higher risk of infectious complication because you go immediately to transplant. You can see even if you compared it to splenectomy or immediate transplantation, the significantly, or not significantly, but there was a trend for a lower relapse incidence rate. So this is the current approach what we did in patients with large spleen who did not respond properly to JAK inhibitors. We give a very low dose of spleen irradiation immediately before we go conditioning, but you can also include it in the conditioning regimen. So we do it fractionate, others do it by a 3 times single shot. And you can see nicely that about 5 centimeters is the median reduction in spleen size if you go for spleen irradiation before transplant. So the pretreatment is important to improve constitutional symptoms, but also to reduce the spleen size, as I mentioned before. So then the classical question is, what is the best conditioning? So in many diseases, we have always the discussion myeloablative reduced intensity. This is a large EBMT study. So you can see there was actually no difference between reduced intensity or myeloablative conditioning. And we did also look for several subgroups where we have a lot of molecular data in this large cohort of more than 600 patients. And interestingly, when we thought maybe that high molecular would be benefit for myeloablative, this is not the case, as you can see here. And you can see also younger patient did benefit more from reduced intensity than myeloablative. So suggesting that actually, that is my personal opinion, that myeloablative conditioning, at least for chronic phase in myelofibrosis, is not necessary nowadays. So the American also checked whether what kind of reduced intensity is better for myelofibrosis. So here they compared the Boo-Flu regimen to Mel-Flu, and because of a more toxicity, they found some benefit in event-free survival for Boo-Flu, while in myeloablative conditioning, there was no difference between Boo-Flu and Boo-Cy. So in Germany and now in the US, there's also treosulfan is approved. And this is a study comparing treosulfan, busulfan as RIC or MAC from the German registry. And you can see outcome were quite similar. So treosulfan seems to be also a good option, especially in older patients who don't tolerate too much toxicity. Regarding the donor, it becomes obvious, and this is just one of the studies, that the sibling is the donor of choice number 1, followed by completely matched and then by mismatch or haplodonor. And in contrast to AML or MDS, where the results for MAD and MID becomes nearly superimposable. So still in 2025 or 2026, match-related donor still is the donor of choice in patients with myelofibrosis. This has been confirmed by the study here from CIBMTR, showing also that with PTCy and haplo, there is a higher risk of complications, especially for non-relapse mortality. So suggesting that cord blood is nearly abandoned because of engraftment problems. So still number 1, matched sibling, followed by completely matched unrelated, and then mismatched and haplo. GVHD prophylaxis is important, but also this disease is highly susceptible to the graft versus myelofibrosis effect. You can see on this study where you can see patients with chronic GVHD, but also with some acute graft versus host disease have a significantly lower risk of relapse. So you should be careful what kind of GVHD prophylaxis you're doing. Since we use a lot of ATLG, we compared it in a large cohort of patients where the ATLG induced a higher risk of relapse, but fortunately it did not. So you can see if you use ATG, you have similar non-relapse mortality, similar overall survival, similar graft versus, you have a better graft versus host relapse-free survival because by adding ATG, you have a lower risk of acute and a lower risk of chronic graft versus host disease. Maybe the same is true if you use PTCy, but for PTCy, the data are so far quite limited. but it could be, and we're still waiting for some new data in PTCI, also using in myelofibrosis post-allogeneic stem cell transplantation. Other options to improve GVHD prophylaxis is to continue the JAK inhibitor, which are now used pre-transplant, not to stop at transplant, so give it during the transplant until day 28 or even later. It's currently under investigation. We compared this approach, which we developed a couple of years ago, with those who stopped JAK inhibitors prior transplant and compared it to those patients who did not received any JAK inhibitors, and you can see engraftment was faster. Graft versus host disease was lower in those patients who received the peri group. And also, even if not significant, it looks like that the relapse incidence is also in favor of using peri-transplant ruxolitinib. So therefore, the GVHD prophylaxis is also crucial if you want to reduce non-relapse mortality. And lastly, I will just give you some ideas which you should also take into account to prevent relapse, which is nowadays higher than the risk of non-relapse mortality. So in EBMT registry, we checked, and you can see that about 18% or 20% of the patients will experience relapse after myelofibrosis. And you can see over the year, there was no major improvement in reducing the risk of relapse. And what we started actually very early, and we just recently make a long-term follow-up, we started also 20 years ago when we started to treat patients with myelofibrosis by allograft. We developed some PCR, first a qPCR, later digital PCR, to monitor a patient with this so-called driver mutation. So the majority is JAK, MPL, or CAL, and you can easily do this in a peripheral blood. And we screened this patient by day 30, day 100, and day 180 post-transplant. And the paper is meanwhile published in the New England, but you can see nicely that the impact of driver mutation clearance is very high for CAL by day 30, about 73 patients already cleared, but you can see also for MPL and for CAL, and then for JAK, the JAK was the lowest clearance by day 180. You can see that the majority of these patients had cleared their driver mutations in peripheral blood. And here you can see on this curve that those who cleared by day 30, they have the lowest risk of subsequent relapse, followed by clearance by day 100 and day 180. While those who are still positive by day 180, you can see they have a high risk of later clinical relapse. So this was also transferred then in disease-free survival. And this is quite important because we know nowadays that with donor lymphocyte infusion, we can, for instance, here, this was an example just 20 years ago, where we monitored in one patient still JAK positivity. We gave DLI, and without any GVHD, this patient could be cleared slowly, but it cleared and then remained negative for the following years. We investigated this more in detail with donor lymphocyte infusion, and you can see that those patients who have only molecular relapse, they can achieve in 88% again a molecular relapse by donor lymphocyte infusion. This was also high, but only in 60% of those who have hematological relapse. And just to focus here, you can see that about nearly 50% of the patient could achieve this molecular relapse without any graft versus host disease. And here you can see patients who achieved molecular relapse according molecular relapse, and this were according hematological relapse. So looking for more for molecular relapse or checking molecular monitoring post-transplant is probably significantly in favor for the patient because you can intervene earlier. And once patient has hematological relapse, you also can cure patients again, but the likelihood of getting another molecular relapse is less than for molecular relapse. So therefore, to conclude here, you can see, we recommend to monitor this patient not only by chimerism, but also by the driver mutations, and then add some, we continue cyclosporine, or we reduce the dose if we have early still persistence, or we gave donor lymphocyte infusion if the patient is still on a molecular marker positive by day 180, once we have already reduced all immunosuppressive agents. So therefore, myelofibrosis becomes a platform now. So we have not only conditioning and GVHD prophylaxis. We start, as I mentioned, with a pre-transplant approach using JAK inhibitors. There's also some ideas how to reduce iron overload by desferrasirox in those patients who are heavily pre-transfused and heavily iron overloaded. We go then for spleen aeration if the spleen still is high because independent of JAK inhibitors. We use only reduced intensity. We add ATLG, and then we monitor this patient very closely post-transplant, and then intervene as well if this is needed with reducing of immunosuppressive agents, or then with donor lymphocyte infusion, and more recently also with some interferon within a clinical study. Yeah, and with this, I would end and thank all the members of my department, but also from all the members worldwide in Europe, EBMT, ELN, and German MPN group, who help to improve outcome in patients with myelofibrosis by allogeneic stem cell transplantation. I thank you for your attention, and I'm open for questions.
Okay, thank you so much, Professor Kroger. And we are going to present the two cases. Pero me perdió Teams. Se me perdió Teams. Se me perdió Teams. Pero la conversación que tengo con él en Teams. Allá. Ajá.
Pantalla completa, no pasa que te voy a echar pero ahora sí comparte la pantalla.
Okay, doctor, are you seeing my screen?
Yeah, I can see this. Thanks.
Okay, we are going to present to you two cases of interest, and at the last part of each one, we are going to ask you some questions. So this is the first case. He's a male of 61 years old, and he has a diagnosis of myelofibrosis since 2018. He's JAK2 negative and BCR-ABL negative. His karyotype is 46XJ, and he has a translocation 1213. Risk scores are in December 2020, a deep score of 3 points, intermediate risk, and in October 2025, a deep plus score 4 points with high risk. Those are the bone marrow studies, and he has the biopsy of the diagnosis with myelofibrosis, grade 1. Cytometry of flow with hypocellular bone marrow and no cellular population with aberrant immunophenotype, and flow cytometry in 11th of May 2025 with a monophenotypic study of bone marrow with 3.8% of myeloid blasts. In November 2025, hypocellular bone marrow with no acute leukemic infiltration, and he has osteosclerosis grade 2, 3, and reticulin and collagen fibrosis grade 3. He went to splenectomy in December 2025, and the pathology was splenic extramedullary hematopoiesis. And this is the last flow cytometry with immunophenotypic study of bone marrow with no evidence of hematolymphoid neoplastic infiltration, relative eosinophilia with increased myeloid precursors, and no phenotypic alteration. And this was a documented progression myelofibrosis grade 1 in 2018 to myelofibrosis grade 3 in 2025, with splenic extramedullary hematopoiesis and advanced osteosclerosis with 3.8% blast and this megakaryopoiesis, and no acute leukemic transformation. This was the treatment. He received ruxolitinib 15 milligrams twice a day, and then 20 milligrams twice a day, erythropoietin 30,000 units weekly for 4 weeks, splenectomy in December 2025, no immediate complication, and he was anticoagulated because he has a portomesenteric thrombosis in November 2025. He received colchicine for pericardial effusion that he developed in April 2026. And those are the complications of the patient in November 2025, acute portomesenteric thrombosis. And in November and December 2025, post-splenectomy fever. January 2026, severe anemia with hemoglobin of 6, and he need red blood transfusion. In April 2026, severe pericardial effusion and cardiac tamponade. And in April 2026, severe hepatomegaly with cholestatic pattern. This is the serial blood count of the since 2019 to April 2026. And he has 2 sons. One of his sons is Jason Valencia. He is an haploidentical donor, and he is 5/10 of the HLA that were searched or analyzed. So here I have 6 questions, and first one is, what considerations will you have regarding transplantation of this patient?
Yeah, this is very difficult because since you started, was this portal vein thrombosis after the splenectomy or was it before?
This.
It was both in November 20.
It was after the
Okay, yeah.
Mm-hmm.
So
it was a complication of the splenectomy.
Yeah. So this patient is, I personally would be a bit reluctant to go for transplant now because you have so many problems which are not clear. Yeah. So this cardiac infusion, pericardial infusion is not clear, or you have any idea why he got this? Did he have perimyocarditis? Did you find some infection, or did you check for
No.
him?
Extramedullary.
We think that was extramedullary infiltration.
The flow cytometry showed the extramedullary infiltration.
From
Vectors negatives.
And is he better now, or?
Yes, ECO 0.
Okay. Then the other problem is his portal vein thrombosis, and which is now becoming more, is his high cholestase parameter, correct? Can you go one back, Anna, in your slide? Another one? Yeah, here the last, in April 2026, which is last month, you have a very high ALP and gamma GT, yeah, and also some jaundice. So did you check by liver biopsy what happens there in liver, or?
No, no, the alteration of functional hepatic test in this moment are good.
So he is normal again, or what are the liver enzymes now? Mhm.
Now his hepatic function is okay.
Yeah, and the lab value for ALP and gamma GT and jaundice is all normal, or?
Yes.
All normal.
Okay. And he still needs blood transfusion, correct?
Yes.
Yeah.
Yes.
And does
sir.
he have varizen? No. Yeah. Hmm?
No.
And
Tiene varices.
Yeah.
Yeah, he has varices.
yeah. Okay. Hmm. So because usually this kind of patient, I would say they have more problems with liver and so on than blood. So usually the mortality in this patient is in my opinion, a bit higher than in others. And if you go to the next slide, Anna. Mhm. Since you removed the spleen, it's also the platelets increased rapidly. So he has now platelets more than 1 million. Yeah. Mhm. Mhm.
Yes.
Which is also not so typical. And mhm. And the blast, does he have peripheral blast in the blood, or?
No, he doesn't have peripheral blast.
Okay. And the erythropoietin didn't work properly, correct?
No. He still needs transfusion.
And do you have access in Colombia to momelotinib as an JAK
No.
inhibitor? No?
No, doctor.
Mhm.
No.
Mhm. Yeah.
Necesito chequear si tienen varios.
He's 61?
Si tienen. Yes.
Yes.
So the only donor you have is the haplo donor. Is this also correct? Mhm.
He's the only donor.
Yes.
Yeah. Yeah, it's not so easy. I don't know the patients, but usually he's not so very high. He's a high risk for non-relapse mortality, but regarding the diseases, he has no blast in the peripheral blood. Cytogenetic is in between. Do we have also molecular markers rather than?
No.
No? Is this possible in your country to look for?
In this time, we are waiting an NGS.
Yeah, I would wait at least for the NGS. Otherwise, I would wait until the patient is really progressing before you go for haplo. Because the risk of complication is pretty high.
Okay, doctor.
Okay, thank you so much. The second question is, which condition and
If you decide to proceed to stem cell transplantation,
Yeah.
which condition regimen will you choose for this patient? I
Yeah.
have a special question about the TBI 400 centigrades, the -1 day before the infusion of stem cells. What do you think about it?
So the majority of data are from chemotherapy. So TBI is rarely used in myelofibrosis. So if you have all options in the world, I would go here for treosulfan because He has some liver problems. He has his varices, and busulfan usually can increase the liver problems. Treosulfan is quite good for liver problems. You don't have any VOD and so on. I don't know whether you have access to treosulfan.
No,
No. Okay.
no, no. Only busulfan, fludarabine, TBI, and maybe cyclophosphamide.
Yeah. Okay, but then you could go for, I would not use busulfan here because of these liver problems, unless you have possibilities to make drug monitoring. You have options to monitor the level or to dose the busulfan according the AUC? No.
No.
Yeah, okay. And yeah, then maybe an option would be to use TBI 4 or 6 or 8 gray.
Okay, doctor. La siguiente.
Espérate que-
So here you have, I would use peripheral stem cells. So would you, the other questions as well, Anna?
Okay, and the other question were if you have any specific considerations regarding the pericardial effusion, or
Yeah,
how will you approach GVHD prophylaxis?
So I would use peripheral stem cells. GVHD prophylaxis, if you go for haplo, you should use PT-Cy. There's no other options, yeah? Unless you have other options, PT-Cy in combination with CNI and with MMF, for instance. And pericard infusion, it depends whether this is now completely resolved or whether this is recurrent. It could be if the cardiac function is fine, it could have been a perimyocarditis, something like that before, if it is resolving good now. But if it comes again, then you should do diagnostic again to check why he's getting all this repeatedly. And Ruxo, I mean, since he has now splenectomy, he has no huge spleen. Does he have constitutional symptoms?
Que si tiene síntomas constitucionales.
No.
In this moment, no.
No.
No. Then because there's no strong need to use Ruxo, I mean, you can stop it before you go for conditioning. Yeah.
Okay.
And do you prefer bone marrow or peripheral blood stem cell collection?
Peripheral blood, because engraftment is usually a problem, but then you have more stem cells if you use PBSC.
Okay, doctor. Let me to continue for the next case.
Espérate que se quedó ahí. Es que mira, salían vacíos.
Good morning for everyone.
Good
I would
morning.
like make just a question if the doctor allow me.
Sure.
Thank you, doctor. I would like thank you for your beautiful speech. I just unique question. Do you think the mismatched transplantation have a role in myelofibrosis, or maybe is unique indication for not related donor source? Thank you so much.
Yeah, as I mentioned in my presentation, still mismatch unrelated or mismatch in general also included haplo. They have a significantly higher risk of complications. This is different from other diseases where, for instance, in AML or MDS, you have similar results. Even with haplo, you have similar results. But this is not true for myelofibrosis. You have to consider that there is a higher risk of non-relapse mortality by using mismatched donors, whether this is mismatch unrelated or haplo. Therefore, if you don't have a proper completely matched unrelated or sibling transplant, the indication for transplant should be very clear. So there should be more advanced disease, or the need should be stronger for going for transplant. So I don't know when you started your donor search. If you are familiar with unrelated donor, I would go look for unrelated donor again. I don't know when you did it, but you should look at least.
No, we didn't do that, doctor.
If you didn't do it, no, you should do this. Yeah, this is important, because here an unrelated donor, 10 out of 10 would be better than an haplo. Yeah.
The security insurance is very hard to authorize the unrelated donor in this moment in our institution, but we can to evaluate the
Yeah, you should. It's for your patients, because the patient is trusting you and he wants to get the best treatment, and the insurance should do the same. It is crucial to have a good donor. This is very important. So you have only limited facilities, correct?
Yes.
Okay.
Okay, so we are going to continue with the case number 2. Are you seeing the screen, doctor?
Yeah, I see everything.
Okay, she's a female of 46 years old, and she has an initial incidental finding of leukocytosis, thrombocytosis, and anemia of normal volumes, with basophilia and eosinophilia, with the presence in the ESP of all forms of maturation of the granulocytic lineage, with 3% of cells suspect of being blast. She has a diagnosis of primary myelofibrosis in January 2026. She's JAK2 negative, and her karyotype is 46XX with translocation 121 P22Q22 with leukocytosis of 1100 previously 16, and no splenomegaly and high LDH with no leukoerythroblastoses. And here's the biopsy of the bone marrow. She has a hypercellular 4H with a cellularity of 90%, with megakaryocytic hyperplasia with this megakaryopoiesis, and myelofibrosis grade 2 with osteosclerosis grade 1 and no acute leukemic infiltration. She, in her family history, have a father with hypertension and a mother died of colon cancer. And she has one full sibling, male, 37 years old, blood type A negative, and the patient is A positive, and one son with 12 years old, A positive. This is her risk score. She has a DIPS score of 0 points for low risk and DIPS plus 0 points for low risk. And she has a MIPS 70 with CALR positive with buff of 26% and CRIP with buff 47%, absence of ASXL1. And that was 2 points with the MIPS 70 plus version 2.0 for a low risk. And her treatment was she started ruxolitinib in February 2026 and aspirin 3 times per week. And there is her blood count cells. And those are our questions. Her conventional karyotype showed 46XX translocation 121 P22Q22 RUNX1 CLCA2 fusion gene. That's a rare alteration describing therapy-related acute myeloid leukemia. And this fusion produces out-of-frame transcript that result in truncated RUNX1 proteins, suggesting a pathogenic mechanism based on the loss of function of RUNX1, a key regulation of hematopoiesis. So what is your opinion of this finding, and will it change the management approach or the follow-up?
Yeah, it's an interesting finding, but it would not change the management approach. So you have to follow this, but it has no implication on the management of this patient at the time being.
Okay, and what's your opinion of the CRIP-BP finding with a BAF of 47.9% in this patient, and does it modify the risk?
No, usually this mutation is very rare. I haven't seen this before. The allele frequencies of nearly 50 suggest that it could be also in SNP, yeah, has no relevance. So it does not modify the risk of the disease. So I would ignore this for the time being.
Okay, and last, do you think the finding of osteosclerosis as a marker of severity is relevant in such a young patient?
No, not for the time being.
Okay, doctor. Thank you so much for the participation.
So this
Another
patient,
question.
just a comment, for transplant, it's too early for this patient. Yeah, I would not
it's
go.
low
It's
risk.
too early, and maybe you can type the brother whether he's HLA identical, but for transplant, it's too early.
Okay, thank you.
Maybe you can add some cytoreduction because she's on Ruxo, if I'm correct. Yeah, but the platelets are still in the million. Yeah, the platelets are still more than million.
Yeah.
Mhm.
Yeah.
I don't
Yes.
know. You can combine it with hydroxyurea or something like that.
Yes, in the last control, we add hydroxyurea for to reduce the platelets.
Yeah. Okay.
The
Good.
Dr. Dominguez, hematologist of this unit, has a question.
Dr. Krager, first, I'd like to thank you for your beautiful lecture. I have a question about what's your opinion about the treatment of patients with primary myelofibrosis and thrombocytopenia? I think that is a challenging treatment aspect because currently in our country we don't have access to pacritinib, so we only have Ruxo, and the patients with severe thrombocytopenia, which is luckily rare in this pathology, poses for us a problem. What's your opinion? Can you give him any recommendations? The use of IMiDs or steroids, do you think is a good option?
So usually if the platelets going down in fibrosis is usually associated with progressive disease. But if you have no other options like pacritinib or momelotinib, the approval for JAK is for Ruxo is only up to, I think should be more than 50. It depends on you and your, so when we have this patient and we benefit and we believe they have a clear benefit of using Jakavi or ruxolitinib, we continue ruxolitinib. Maybe we reduce the dose and we tolerate also a low platelet count unless they are transfusion dependent for platelets. The approval is clear, should be higher than 50, but we are hematologists, so we know to deal with low platelet count. So this is nothing, no rocket science. So if your patient and you have no other options, and if your patient is really benefiting from Ruxo regarding spleen size, constitutional symptoms, then I would recommend to continue, even if the platelet count is less than 50. But regarding other options, so IMiDs are also myelosuppressive. So with IMiDs, you can also see worsening of thrombocytopenia if you use lenalidomide or others. There is really no good option for these patients regarding the platelet counts unless you have no access to pacritinib or momelotinib.
Okay, thank you. I also have another question, and it's the WHO 2022 classification established a new diagnosis of MDS with fibrosis. What are your thoughts about that diagnosis, and maybe if the only way to differentiate that between primary myelofibrosis and MDS with fibrosis is the morphology, because we can see some megakaryocyte atypia, and that maybe in the morphology aspect confused the and make some questions about in the pathology lab.
Yeah, so usually it's not so difficult to distinguish because MDS with fibrosis is not so uncommon. It's mainly in secondary MDS for pretreatment. So usually these patients have at least dysplasia, which you usually don't see in myelofibrosis so much. The molecular genetic is usually a bit different. They have other mutations more in MDS. And also the cytogenetic is usually different. And these patients are more cytopenic, while in MPN you have more proliferation, at least in the beginning. So the major differential diagnosis is actually pathologist. So you have to do a bone marrow histology, but usually these patients don't have a huge spleen. They don't have constitutional symptoms like fibrosis. So it's, in my opinion, it's not so difficult to distinguish. And also the grading of fibrosis in MDS with fibrosis is usually grade 1 or 2. It's very rare grade 3. And also these patients have usually more p53 mutations, the MDS with fibrosis, than the myelofibrosis.
Okay, thank you.
Okay, Professor, thank you so much for
Okay.
being with us.
Yes, it's an
Okay.
honor, I repeat. And we wait to visit Colombia in any time. You are welcome to Clínica Valle del Lili from Cali, Colombia. And thank you for all your advice and your presentation. Thank you so much.
Okay, it was a pleasure. Good luck for you.
Can we ask access for your slides?
Yeah,
Thank you so much, doctor.
yeah, it's a pleasure. Bye-bye. Take care.
Bye-bye.
Thank
Bye.
you.
Suspender la grabación. Bueno. Chicharracito.
Creo que me vuelve la pantalla, por favor. Ah,
Por acá, record. Él fue presidente del EBMT, presidente de la Asociación Europea de Trasplantes, durante alrededor de 8 años.